Dear all, Namaste. Today I shall be discussing on malignant otitis externa. This condition is defined as rapidly progressive infection of external auditory canal spreading to surrounding soft tissues and bones of the skull base. This condition is a misnomer. Chandler in 1968 defined this condition as having aggressive clinical behavior spreading rapidly, poor treatment outcomes because the patients were usually uncontrolled diabetic patients of elderly age and high mortality in elderly uncontrolled diabetic patients. So this was called as malignant otitis externa, but this is a misnomer. It has many synonyms. They are invasive otitis externa because it invades to surrounding structures, granulomatous otitis externa because there are granulation tissues present between the bony and cartilaginous portion of the external auditory canal, and necrotizing otitis externa because there is necrosis of the adjacent perichondrium, cartilage, and bone. It is also called as skull base osteomyelitis because there will be osteomyelitis of the skull base, which rapidly progresses to involve the skull base structures. What are the predisposing factors? As already told, they are elderly individuals, poorly controlled diabetic patients, patients on prolonged steroid use, atherosclerosis, immunocompromised individuals, and patients with HIV/AIDS. They are more prone to get the disease. Let's come to the causative organisms. Pseudomonas aeruginosa is the most common causative organism. Staph epidermidis also can cause disease. Aspergillus fumigatus is the invasive fungal condition that also leads to malignant otitis externa. The hallmark of disease is granulation tissues at the junction of cartilage and the bony external auditory canal. What is the pathogenesis of this disease? This is also a very commonly asked question in the exam. There will be subtle trauma to the external auditory canal. Patient may have the habit of cleaning the external auditory canal. When the patient goes to swimming, the water may enter the ear and patient might use the instruments to clean the ear, and Pseudomonas grows there, leading to Pseudomonas infection, and that leads to granuloma between the bony and cartilaginous portion of the external auditory canal, and that granuloma spread to parotid gland, TMJ, and adjacent subtissues through fissures of Sanzolini. The granuloma may extend to tympanomastoid suture and adjacent subtissues, leading to erosion of tympanic plate and mastoid tip, which leads to facial nerve paralysis. It may also lead to secondary osteomyelitis of the skull base and petrous apex, leading to 9th, 10th, 11th, 12th cranial nerves paralysis, and the disease can spread to the brain also. And there may be thrombosis of the lateral sinus, interjugular vein, superior and inferior patellar sinuses, and the infection may spread to the distal areas as thromboembolic phenomena. This is the pathogenesis shown in the picture. What are the clinical features of this disease? There shall be severe earache in predisposed individuals, more during night time. The pain will be out of proportion of disease in the external canal. In the EAC, we will only see the granulation tissues and sometimes fluorescent discharge, usually mucoid to mucopurulent discharge. There shall be swelling of the pinna or face leading to cellulitis. There may be a discharge which will be initially mucopurulent and later blood stained and purulent. As you know, there will be formation of granulation tissues, granuloma, necrosis, and involvement of the other structures. The patient may have conductive type of hearing loss, and sometimes there may be SNHL when the patient has labyrinthitis. The patient may develop 7th nerve paralysis or polyneuropathy of 9th, 10th, 11th, and 12th cranial nerve in the skull base. When the patient has fever, headache, neck stiffness, then we have to think of intracranial extension of disease. On examination, the pinna will be hot, tender, and there will be mastoid tenderness as well. If we look through the otoscope, we can see swollen external auditory canal and granulation tissues between the cartilaginous and the bony external auditory canal, which is the hallmark of disease. What are the investigations carried for this condition? They are complete blood count to see raised total counts. The patient will have infection, the patient may be toxic, so we have to look for complete blood count. We have to look for blood urea creatinine also. Patient may have septicemia or septic shock. The patient may have raised ESR, which signifies active disease. So ESR is one of the important investigations to be performed in patients with malignant otitis externa. Fasting and postprandial blood sugar are also to be looked for. They are the indicator of diabetic control. Ear swab has to be taken from the external canal pus if Pseudomonas comes in culture, that is diagnostic of malignant otitis externa, because around 95% of patients may have Pseudomonas positive in culture. CT scan and MRI, they help us to find out the extent of disease, bone and soft tissue involvement. So skull base involvement, brain involvement can be seen with the help of CT scan and MRI. Other better investigations are gallium and technetium bone scans, which are better than CT MRI. And basically in technetium scans, the radio tracer concentrates in the areas with increased osteoblastic activity. So when there is active disease process, the bone scan is more important than CT scan and MRI. Even bone scan can be used as the indicator for disease control. When the disease gets controlled, then there will be less uptake in the skull base. How to treat malignant otitis externa? The first and foremost thing is to control diabetes and other predisposing factors as discussed in the predisposing factor part. Oral toileting is to be performed. The debris are to be removed, and sometimes IG pack is to be kept in the external canal to decrease pain and to decrease the edema also. We should administer antibiotics against Pseudomonas aeruginosa, high dose and broad spectrum IV antibiotics like piperacillin and tazobactam, 4 to 6 gram IV every 4 to 6 hours till the disease is controlled. Ciprofloxacin 750 mg twice daily for 6 to 12 weeks as oral dose, and ciprofloxacin 200 mg IV twice a day for active infections. Ceftazidime 2 gram IV 3 times a day can be also given because they are the anti-Pseudomonas medicines. When the patient becomes better, then we can start an oral antibiotics, and we can see ESR also. When the ESR gets controlled, then we can start an oral antibiotics for a few days. The patient should improve with the use of medications. Hyperbaric oxygen therapy also has been tried in cases of malignant otitis externa. This increases local oxygenation and improves hypoxia and leads to greater oxidative killing of the bacteria. So this may be useful, but this is to be used in adjunct with the antibiotics only. A note for the undergraduate students is that when you are an intern, when a patient comes to you with a history of diabetic mellitus, severe earache, ear discharge, swelling of the pinna, and involvement of the cranial nerves, you should think of malignant otitis externa and you should treat accordingly. Thank you very much.